Okay.
I have started.
There we go.
There we go.
Off we go. So excellent. So the recording started. We'll start talking about things. So, as I said, I'm from the Children and Young Persons Neurodevelopmental Partnership, and part of that work, Ash and Chris are part of things, and Kirsty as well moving forward. So we are a partnership. So there's elements of health and education within that. So hopefully we'll be able to answer questions from both spheres today, as we try to each time we run one of these. So if on the next slide, so. Now, this launches straight in, and we're very conscious of the fact it launches straight in. And we've done that on purpose because quite a lot of the previous training we've done, we talk about the pathway and the partnership and the graduated response. We've also, there's some other sort of training on reasonable adjustments and things like that on the local offer, which I'm sure some of you attended. But if some of you didn't, then all the recordings are available on that link that Harriet put up a minute ago. Now, the beauty of that is that it means we can go straight into this. So I'm sorry if this feels like we're jumping into the middle, but it might be worth going back and watching some of those other presentations if it helps. So when we're talking about a graduated response, we're talking about having a good understanding of a young person's needs and meeting those needs without a diagnosis. We also then go on to talk about young people on our waiting list. Now, we're quite open about, the time to wait with our waiting lists. We also do work really hard to provide support, signposting, and some interim support and some outreach work for those that need it, for those young people waiting on the waiting list. So that being said, like this slide says, families are also welcome to seek a private diagnosis. That sits within, sort of every sphere of health within the country. The CYPMP has a commissioned role to review privately funded autism and ADHD assessments so that we can determine whether the Somerset system can formally accept any diagnosis given. Now, we need to do that on a case-by-case basis. We haven't got, a sort of guideline to approved private assessment. That isn't something that we're able to do, and actually it would be part of our sort of legal setup as things stand at the moment. So on a case-by-case basis, we will assess those private assessments to ensure that they would be accepted by the Somerset system. It's not essential for us to do that, and we would need the young person and or the parents' consent to do this, but there are some things within the local system that would need that. So for it to be named as a diagnosis on EHCPs, for example, it would need to be accepted through the Somerset system if a private assessment had been accessed. Again, however, within the EHCP system, you do not need a diagnosis for an EHCP. Equally, a diagnosis doesn't automatically get you an EHCP. So again, it is completely up to you as a family and your young person if that is something that they want. So it's not essential.
Could on that, could someone just copy and paste the myth busting document, which that would be quite a useful link to look at while you're going through this.
Absolutely, yeah, brilliant. Thanks, Harriet. Unfortunately, we do know that there is a wide variation of robustness of privately funded autism and ADHD assessment, and it's important. That's brilliant, thank you. It's important that all assessments comply with NICE guidance. There are some brilliant ones out there as well. We're not sitting here saying that sort of we are worried about all private assessments at all, but we do just need to make sure that they do comply with NICE guidelines. So we've created a local position statement on private diagnosis. Again, that's on the local offer that was pasted in before into the chat. And it says the details of exactly what was expected of an assessment and what we would need to see in a report. So we would need to be able to see that it covers all of the key points that NICE have indicated is a compliant assessment, and that includes background history, that includes contextual clinical information, direct clinical observations. Some of those can be online. Most private providers are, sort of online, but they still need to have direct observation of the young person, also have the voice of the young person and sort of people around the young person that are looking after them and meeting their needs. So to be able to do that, families need to email the report, the assessment report, the full assessment report, not just a diagnosis letter, but an actual report that includes all of that background history and the clinical information gathering and everything else that it says in the private position statement. And they need to send that through to Child NDS, as you can see on the presentation here. We can then review that private assessment, and we'll get back to you with a letter saying whether or not it's been accepted by the wider system.
Okay.
Oh,
Mary, is it?
have I changed the screen or not?
No, you haven't. I'm just wondering, is it worth stopping and seeing if anyone has any questions directly related to that before we move on?
Yeah, absolutely.
So if anyone's got any questions on that particular point that Mary's covered, let us know. Otherwise, we'll move on to right to choose stuff. Feel free, by the way, to talk out. You don't need to type in. You can just put your hand up or talk out.
No, we don't. Sorry. So the question is, do you have a list of approved people? No, we don't have a list of approved providers at present. That's we're not in a position to say, sort of who's an approved provider or not.
Okay, I'm going to assume that is no other questions. So I will move us on.
So right to choose is part of this sort of an NHS legal framework. So it's the right to choose applies to the following criteria. So the patient has an elective referral for the first outpatient appointment. The patient is referred by the GP. The referral is clinically appropriate, and that's really important part of this. And the provider has a commissioned contract with the ICS or the NHS England for those required services. So when we're talking about approved providers and things like that, that's different for right to choose. There will have to have the right commissioning contracts for right to choose providers, but again, we need to be able to review those in the same way as we do privately funded assessment reports, because they are often NHS partners. So where it says they are commissioned contract with the ICS or the NHS England, that what that's talking about is the fact that they might be an NHS partner but from a private provider. So what we need to think about then is we need to ensure that it's NICE compliant, and we would accept it into the Somerset system. So I think the right to choose does go via the GPs. GPs have, sort of it's their discretion to say if it's clinically appropriate and necessary for that young person to be referred. And it's really important that the GPs feel confident and have the knowledge to be able to refer that young person through, because some of those some of those commissioned contracted those NHS partners may well require as much information as we do. And as we know, the information on the next steps form would be very, very difficult to have enough information as a GP for, about that family unless you've worked with them for a significant period of time. So there are some drawbacks, and it's not, sort of a given that anybody that goes to the GP and says, I want a right to choose, that's the right pathway for those young people. So we need to make sure that it's, it's the right people. So are there any questions about that?
I think a big thing here, I don't know if we talk about this later, Mary, I think maybe we do, is around the lack in post-diagnostic support through this route, isn't it? It's so there's one of the great things about doing it all through the CYBMP is that we have a kind of a path through, a thread of what has been supported to support the young person, and then we have the diagnostic process, it's the assessment process itself, and then we have the post-diagnostic process where we're looking at, okay, now we've got that, what is the next? And that's where we have these PIFUs where we will do parent-initiated follow-ups, and we can talk through patient initiated, I always get that wrong, and talk through the with the families and the young person about what that means, and sometimes that's with the schools as well, so we can have this collaborative understanding of I guess what that means in practice. I think, is Charlotte going to go more into
if she's joined us by then, that'd be great. Okay. But we've got some more slides on that, so we can talk about that.
Brilliant. Okay. So it doesn't look like anyone else has any questions on this, which is good. That means it must be well understood. If you, here we go. If children are on a pathway but parents then go through R2C, do you get notified that they are going via this route?
No, we don't. There's no automatic informing us. So what we tend to find out is when we have the assessment report sent through to us for us to ratify, we will then see that they're on our waiting list, because we would see that when we uploaded it onto their record, when we received it for ratification. And actually that has been a problem in the past, which is why we put together the private position statement in the first place, was because we would often get young people that would get to the end of an assessment where we would then say, so the outcome of the assessment, and they'd say, oh, that's brilliant, thank goodness. That's what the private assessment had said. Now, obviously, that's put the young person through 2 assessments, and that is also, that's taken time and sort of away from what was necessary, and that's why we set up the pathway where we could do those. We can do that private ratification, which is what we've, sort of equally used the same framework for the right to choose assessments. So we do use both of those frameworks to ensure that parents are aware that they don't then need to sit through an assessment again with their young person.
Sorry, may I just ask a question? I'm on my phone, so I can't type in. Is it okay to talk out?
Yeah, yes, absolutely.
So I have a parent who came to see me last week regarding a referral, and she discussed the right to choose option, and I said that it would need to be done by her GP. But I was really keen for her to sort of collate all her thoughts on the next steps form, and for us to do that as well. So my plan is that we complete the next steps form between us, then mum takes that to the GP herself and uses that as a referral in regards to her right to choose. Is that the right approach?
So collating all the information and using the next steps form is a brilliant way of having some really, really good conversations. The next steps form is obviously a tool in itself in terms of, sort of having those conversations and opening those doors to talk about who's seeing what where, and, sort of how the young person's presenting in different places. So I think that's a brilliant idea. Whether that will be used in a right to choose is unlikely, because what the GP will have to do is complete the form for that service that they are referring over into. So my understanding,
that might look completely different then, but they could
potentially.
They could translate what they'd read on the next steps form though, and put that.
It would be really, and I think it's a really useful thing to do, and I think it'd be really helpful as well for the family.
There would be no point me referring that to the pathway as well as it going to the right to choose option.
I mean, I wouldn't like to advise you to refer into both. I think it's worth having a really frank and clear conversation with families, and saying, sort of, it depends on what the waiting times are for the right to choose, because they are varying now. They're not as, sort of speedy as they necessarily used to be, but also that all the help and support available through obviously the Neuroaffirmative Support Hub, all the help and support that's available while they're on our waiting list won't be available if they're not on our waiting list, but you can't be sitting on 2 waiting lists. So it's, sort of, I think it's worth having a really frank conversation about that, but people have, sort of, as long as it's an informed decision, that's absolutely fine, whatever people want to do.
Great, thank you for clarifying that. Thank you.
That's no problem.
Someone's asked a question here. We've had parents going on right to choose after acceptance on the pathway. Then we as a school have been contacted for a large amount of information online type form. Does this mean that our paperwork doesn't get shared with them?
Yeah, no, we can't share our paperwork with right to choose, I'm afraid. The right to choose is totally separate, it's out of county, so that's not something that we do.
So part of this, and part of what I'm going to talk about in a minute, is that this is all part of all of what we're doing. This information gathering should all be part of the Somerset Graduated Response anyway. So a lot of this should exist, but in terms of that particular bit, and then that doesn't get shared, does it? Once it actually the form itself that's just captured with CIPMP.
Yeah, I mean, you're more than welcome to send them the information you've already sent in to us. But if they're insisting on a different format, unfortunately, That's part. Yes, that's.
Okay, next question here. Where are we going? There seems to be a lot of variation in GP responses to the right to choose request. Is there a policy?
It's clinically appropriate. So,
Oh, yes. Yeah.
sorry. So, yeah, it's just whether it's clinically appropriate, and that's down to GP. Sort of whether they deem it to be clinically appropriate and right.
If a right to choose provider is NICE approved, is it still possible that Somerset will not ratify it?
So we ratify everything on a case by case basis. So a provider, so each everything that we work through, we would need the actual assessment to be NICE compliant. So we don't deem a particular provider non-NICE compliant. So we aren't saying that. What we have to do is we look through each individual one and check that there is all the elements that we would need for that particular assessment to be NICE compliant, and at which point we would then ratify it.
Okay. Has anyone else got any questions for now on anything to do with right to choose? It is a complicated process. There are no silly questions here, so please do.
And there will be questions and processes and things that actually primary care would have more knowledge and information, because they would be the ones that would be doing it. And so we could arrange for somebody from primary care to drop in at another meeting as well, if that is something that people have got an appetite for.
That's a good idea. What happens with medication if they get ADHD diagnosis via right to choose?
So I think that we'll come on to that in a minute, but I can say it now, so that's fine. And we can, so once we ratify an assessment, then we can, then they'll be put onto the ADHD pathway, and they'll be offered the Understanding ADHD course in exactly the same way as, as anyone that we diagnose. At which point they will then have 6 months of scaffolding. So offered the ADHD course at some point through the next term, and then they will have be given 6 months of scaffolding after the back of that. And then after they've managed the scaffolding and they feel that they, they have the strategies in place, then they will be offered an appointment with an NMP and to discuss whether medication is felt to be the right thing, and then. So if that does become something that everybody thinks is the good thing, it would be helpful for the young person. At which point the young person would obviously again need to give their consent, and then that can be talked through. They will get another appointment with someone who can begin that medication, and then it will be titrated. But they will have to have at that point they will need to be made sure that they're sort of clinically safe to have that medication. So they will have sort of cardiac exam and things like that.
Okay, there's a lot there, and we'll be unpacking that a bit more, I think, a little bit later as well.
Yeah.
Okay, I think that's that bit covered, so I am going to move on. So if I talk a little bit around this, so this is something I know we've spoken a bit about in the past, and ties quite closely to right to choose, because what we're trying to say in Somerset and nationally essentially is that all forms of support are available on the basis of need. So what a person can get with a diagnosis is very little compared to what they'd get without the diagnosis. What we're essentially looking is, what is this presentation of need? What is going on for this young person in this particular context that means that they need some form of additional support? And that's where there's the graduated response toolkit. There's also now the neuro graduated response tool. Harriet, I know in the past we found this tricky to find. Could you find the link and pop it in the chat? It's very similar to the graduated response, but it's essentially it's something that's focused for our neurodivergent children, and it takes us through the idea of what are some of the things you might put in place at those various degrees of universal support, SEN support, and then high need. So it's quite a good it's quite a good thing to have a look at and go, right, where is this young person struggling? What is my support options available? Because there's a lot of support available in Somerset in theory, but accessing it and where to go for those links can be quite a challenge. So that is quite a useful document to find that.
I think the other really useful document now, Ash, it's worth mentioning, is the new book that
yes.
Parent Carer Forum have just released, that they launched last week at the conference. So that is the How to Support My Neurodiverse Child booklet, and it's got lots and lots of information, which is really helpful. Again, it's not about, sort of young people who have a confirmed diagnosis. It's about recognition of need and what support they need, and how to look at it. And it looks like Charlotte has just joined us, so that's great, Charlotte.
I'm so sorry. My clinic this morning has been very long, so I'm running a little behind, but I am here now.
We're just pleased to have you here.
Yeah, that's brilliant.
Thank you.
So that booklet, if anyone has a copy of it, can you put a link on? If you haven't, if nobody can find it for now, don't worry. We will make sure that the link and the booklet is available on the website.
So we have electronic copies available, and we're hoping by the end of July there will be hard copies doing the rounds. So and I think they'll be available through Parent Carer Forum for any of your parents that you're working with. And the link is available on their Parent Carer Forum website.
Okay, we'll make sure it's available on the Somerset one as well. We'll get it as many places as possible.
Oh, there we go. Thank you very much. Amazing.
Okay, so when we're talking about this, so gradual response. Okay, so this is the idea that we're gradually increasing the amount of support that we're giving. When we're looking at neuroaffirmative support, we're talking around what are some of the areas that we know make a huge difference to young people within those settings. So there tends to be a typical things that we can kind of go to and think about what is happening for this young person, and often these tend to be sensory based. But what I've got, just seeing if there's anything else I'm missing in, what I've got that will be quite useful here. Let me see. Was there anything more you guys want to talk here? I was going to talk through the space thing, but I don't want to miss anything that you guys wanted to highlight. No, okay. If I miss something, the
space plan covers it all, Ash, doesn't it? Because they're the things we see coming up again and again that feel quite small to us, but make a huge difference to our neurodivergent young people if we can do those things.
I'll talk through that then, and then do chip in, guys, if I've missed bits. So space, for those of you who've not seen, it sounds cooler than it is, but it stands for sensory, predictability, acceptance, communication, and empathy. So these are essentially a theoretical area within the literature which says, right, these are key areas where children with neurodivergence struggle. What we're trying to do with the space support, I'm just going to skip to this for a minute and then I'll come back. So what we're trying to do with the space plan is to go, right, what are the most important things that can make a potential difference to this young person at this point in time? It's really difficult to kind of get a whole picture of a young person and go and be put everything in place that we think would fully support a young person. What we're trying to do is go, what makes the maximum difference? So when we're looking at this, we're thinking, okay, sensory. This is an example of one which we've done in the past through a school project with the CYPMP, but this is available to everybody. So what you're looking at doing is thinking about these different areas and thinking about what makes a difference. So here we've got about benefits about being encouraged to take regular movement breaks. This is a key area. So if I was to say to you, what are some of the primary things you could do for a young person, let's say who you feel is presenting with behaviors that you might think, okay, maybe they've got ADHD, maybe they are struggling to focus in the classroom, maybe they're struggling to sit still, maybe you see them constantly fidgeting, and maybe you're getting sick and tired of saying, look, can you just watch this, please? I have been there when I used to teach. There is key things that can make a huge difference, and one of these is movement breaks. So being able to identify the thing that will make a difference to a young person is huge. Once you've captured it, we want to put it down on this, because often the difficulty is creating that consistency where we're going, right, how can we make sure that this setup that we know works for this young person can be disseminated to other people in the school, so that we're consistently supporting in the same way. So some of the other ways here is sitting at the back of the class, or spending some time regulating. So there's three, I would recommend probably no more than 3 bullet points on each of these areas. You'll probably see it's fairly similar to the one-page profile, which you would have done in the past. It's the reason we've changed it to look like this is because this is a very neurodivergent approach. So we're looking at the key things. So next you've got predictability. So it's around that consistent, having consistent routines, making sure changes are known in advance. There's one around boundaries. These aren't things. So what I'm not saying is you should copy and paste this for every child. What I'm saying is this is an example of a young person where we've created this, and this is then in the classroom somewhere for the young person, not obviously up on the wall, but somewhere where the class teacher or supports can access this, and they can really easily just go, right, what have we got to do? And it's like a snapshot of the young person. I'd recommend, if you're doing this, if you've identified a young person who you feel is potentially neurodivergent, the way to come about doing this is through your typical graduated response. So what you're first looking is seeing what is putting something in place that is different to what you typically put in place with the rest of children in the school, and then evaluating it to see if it's effective. And at that point, we're saying, okay, it's effective. Now we want to start putting it on this. So this can be used as part of that APDR, as well as it's a useful tool in itself.
And I think what we found really helpful, Ash, haven't we, in the use of these within the project with some of our schools, is that it's about the young person and the parents also having access to this, so everybody knows what support is being offered, because we know that schools are often doing brilliant things to support young people, but the families might not realise, and actually having a copy of this is so helpful for them to realise the different areas that you're supporting every day. And the space plan also comes from a healthcare background. It was initially used to support neurodivergent young people accessing healthcare appointments. So it's about encouraging our families and young people to use it outside of the school environment. So it works across multiple different settings. Mm-hmm. So if you can do it as a collaborative thing, that's even better, to share it with your families, so that they know just how much support is going on in school, because we know it's happening, but we often hear that, don't we? I'm not sure what they're doing in school to support, even though we know there's lots of brilliant stuff going on.
That's a very good point. Thanks, Charlotte. So yeah, when you're creating something like this, so you might have the information available to you in school. When you're creating something like this, bringing everybody in who knows the young person best, and including actually the young person if they feel confident enough to do so. There's a key thing around allegiance, where if we can get the young person involved, they're more likely to feel that sense of belonging and want to engage. So if we're able to get their voice, build that into this, it's and then we can review it. So you're looking at that 6 to 12 week review process and going, right, does this make a difference? If it doesn't make a difference, then get rid of it. Or at least, if there's individual things that you're finding actually this is not useful anymore, get rid of it. Okay, this is an ADHD task planner. By the way, this space plan will create a link for as well. So any information you've got here, we'll make sure it's that you've got a copy of that somewhere. This was just another task planner. So when I'm working with schools, I'm often trying to find what are the key bits of information that can be most helpful. This is just a way that we're looking at when we're thinking about ADHD children. It's often those executive function skills that they are struggling with the most. So this is just a simple worksheet to go, right, what is my first task, what's my next task, and how can I break it down? Any way that you can support a young person to to access this task independently through this is going to be really positive, because what can happen is, and this can happen from quite an early age, if a young person comes to think of themselves as being dependent on an adult, so sometimes what can happen is we might end up saying to the young person, right, now you've got to do this, now you've got to do this, now you've got to do this. And the problem with that is that the young person comes to think that, like, they need somebody to tell them what they've got to do next. So this is essentially a scaffolding process to breaking down those tasks. So we're writing it down, we're going, right, first I need to do this, then I need to do this, and then they look at the task and support it themselves. This takes training. So this is a supporting the young person to think about how they can access the tasks more independently by themselves, but not feel that they need the adult, but also knowing that they've got some sort of support mechanism in place. CERTS. So CERTS is still going. If anyone has not heard of this is a support in Somerset that we use to support our children, primarily with autism, but it's shown to be quite helpful actually with all children, especially children with neurodivergence. But it's essentially a focus on relations and relationships, and how we can think about different ways to support them, which tune into their motivation, their sense of desirability. This worksheet that I've provided is a really easy way to put yourselves into their position and think about what is working here, what could we do next. It's a reflective sheet, but what I want to show you and just highlight is next year, so from September next academic year, there was additional CERTS training going on. So there's 3 days of CERTS. It's quite a commitment, but it's free. It's only going to be happening. So next academic year is the last year that we're going to be putting on CERTS. I'm 99% positive. We did say that last year, but I'm 99% positive this year will be the last year, because it is quite expensive, but it's free for schools, for you guys. So please do.
It's a brilliant training, isn't it, Ash? It works so well because actually it fits with all those things on the space plan. So yes. For people who are not used to it, it stands for social communication, emotional regulation, and transactional support, which all tie in so nicely to the letters of the space plan, don't they, in terms of what you're going to do to try and work with that young person. Yeah. And I was just thinking that one at the top there is so key for our neurodivergent young people. Why do they have to do something? I think this comes up a lot in clinic, the explaining the why to young people who perhaps don't have the same social drive to do it that others would have, kind of making sure they know why they're being asked to do the task, and why that behavior is being enforced in a certain situation can make such a difference to them being able to attempt it. So yeah, I'd really recommend it as a training.
That's absolutely right. It is well received. It's a hefty commitment, that's all. I mean, it's 3 days, but it's worth it. And there's a lot of follow-up support and these type of worksheets which can be quite useful. There's also quite a lot of people now who other schools in Somerset who are doing it. So if you find yourself thinking, well, you really want to, you've gone to the training, you really want to do it, you need a bit of help, there are schools around who can support you to implement this. So in terms of the days, so this is on, if there's it's very good. She's already put the links in. So we've got the day 1, October the 16th, day 2, November the 4th, day 3, the 21st of Jan. Often we have little follow-up sessions as well, like implementation sessions, because the hardest thing with training, you get this 4-day training and then you do it, and it's like, how the heck do you do it in practice? So there are these follow-up implementation sessions as well that we're normally run. It doesn't look like we've got them advertised yet, but hopefully they'll be in place. But as I said, there are schools around who are running these. Oh, thanks, Kate. Kate's just volunteered for the whole of Somerset to talk about schools, because Kate's school is a Search Champion. There are other Search Champion schools. I can't remember who they are. Okay, was there anything else there, guys, that I've missed on that one? No, brilliant. Okay, let's move us on. Okay, I'll pass you guys over to Mary and Charlotte. I feel like I've spoken a lot.
So I think the next bit, so sort of linking those two together really about, so Kate's now really panicking that not the whole of Somerset, so that's quite funny. But so linking back with the sort of the information that we were giving at the beginning in terms of people feeling that, so they need to have an assessment immediately, and they need to have, sort of go down the right to choose, or they need to have a private assessment. And we have all got, we've got all the provision in place to support where that's needed, and where that feels appropriate for the family. But what we don't want anybody to do is to feel desperate to have that assessment. What we need to be able to do is look at all these tools and things that we can implement, like we've just been talking about, to ensure that people have their needs met, so the young person can make an informed decision about whether it's something that they want to do, and whether it's, sort of something that they want, whether they want a diagnosis, that is a lifelong diagnosis, and whether it's an assessment that they want to have. So at that point, and that our in sort of consent gaining is always done in sort of in an appropriate manner, for age appropriate manner, and cognitive appropriate manner. However, we do have reasons why an assessment is appropriate. So it's not to enable recognition of need, and it's not to inform decisions about school placements or EHCPs, and we've talked about that earlier, which is why we know that we've put the myth busting in the chat as well. And it's also not to access support, because we need to look at those needs and assess those needs, but over and above sort of what the diagnosis is, because all needs will vary even with a diagnosis. So the diagnosis isn't going to help support need. It is, though, there to support self-understanding and acceptance of being different. It is there to promote emotional well-being and positive identity development. It is also there to offer a layer of protection to prevent unnecessary harm caused by misunderstanding. And that's misunderstanding of people around you, misunderstanding of themselves. But all of those things also with the green ticks, it's not just an assessment or a diagnosis that can start to build those, to build those building blocks. It's really important that all of the people around our young people working with them can start building those blocks without an assessment. We can already start acceptance of being different. And I think there was a few slides back that we needed to skip through, because we were looking at the the models of support, like the SPACE model and CERT. But there was lots of information in there about what to do about acceptance, and how do we accept young people for being different, and how we can support young people to accept themselves, and to realise that all of these support that we put in place aren't because there's something wrong with them, and aren't because we want to change them. And actually, it's just about saying, actually, what we need to do is change a few things around you, so that you have, the ability to be the best version of yourself. And I think that's something that we really need to support. Charlotte, do you want to add on to that?
Yeah, I was just going to add to say, I think that, that what we're talking about there are the benefits of an assessment, really, aren't we, rather than a diagnosis, because not all of our young people will get a diagnosis, but hopefully they will get that understanding of themselves, and, that beginning of accepting what that means for them. And you're so right, Mary. We talk a lot in autism about the double empathy problem, and about not needing to change our young people, but both sides needing to understand that their way of being is equally valid. And I think that can be really hard, can't it? Sometimes we're trying to get everyone to be in the same way, to learn in the same way, and it's kind of being aware that not giving eye contact is an equally valid method of communicating as it is to be in a situation where you're quite happy to give eye contact. That's something that kind of schools can support so much with, around celebrating difference and neurodiversity. So I think that is really important. And we, the vast majority of the young people we see want to have an assessment, but they're in the best place for it if they've already thought about those differences with the people that know them really well, and that's you guys at school and their parents at home. That's when they come to see us and they're excited to have an assessment. They know exactly what they already feel proud of in themselves. It's a very different place to start from, isn't it, Mary, than if we begin an assessment with a young person where we're only just, I had a 17-year-old last week who had only been told by family and school the day before that they were there for coming to see us for an assessment to consider autism, and that then is a big shock. So we want to see our young people in the best possible place to conclude their assessment. And the numbers are tiny who refuse an assessment, but it does happen. There are young people who are quite adamant they do not want an assessment or they do not want a diagnosis, and that's also valid. We will not, be forcing young people to have assessments if it's not something they want to engage with.
Absolutely. And I think so the slide as well that we've got up at the moment is about masking and about young people sort of reaching a point where they mask and feel that they need to socially conform, and all of this feeds into into that. So acceptance of self, but that acceptance of self has to start from from us and the people around us. So it can't start from the young person themselves. So I think so there is some other training that we did on masking, but masking is the result of a young person feeling the need to behave in a way that isn't their authentic self, and that they have to pretend to be something that they're not, and that's the start of it, and then it builds on from there. And there will always be some social pressure from their peers, but the more accepting we can be as adults around our young people, the more that will be mirrored in their peers and the settings that they're in. Do you want to add on to that, Charlotte?
Yeah, only to say the reason I think we go on frequently about masking is because we know how poor the outcomes are for young people who end up having to mask all the time, in terms of their mental health and in terms of things like autistic burnout. It's a very tricky place back from those things. So we want to try and support people earlier rather than when they get to the stage where they just can't hold it all together anymore, and then their mental health's really suffering. But we did a training on masking that's on the local offer website if anybody wants to view it. I know that Gemma put it up a while ago, so
it's really helpful, that training. I think all this kind of drives back towards the idea of why we keep talking about the relational approach and the importance there, because this is where we get to know the young people, get to know what are some of those subtle differences, and think about how we can best support them. And if we know that information, that's how we can build on the space plan, because then we're more likely to be able to produce something that impacts upon them. Okay, so let's
back on to next. Yeah. So then, talking, apologies. Talking about what we have available while young people are waiting, and we've talked a bit about this already. So this was just a slide about the fact that obviously through the helpline, through TAL, there are some outreach work that we can do to support, and all of that is available through the helpline. The helpline is available for everybody, so it's available for families, it's available for you guys, but it's also available for young people. And we do occasionally get young people phoning up, and it's really it's actually really nice for the clinicians to have a chat with the young people themselves. It's always a good day when the young people use the line themselves, so that could be encouraged as well for some of the older teenagers who you guys are working with. So please do encourage that. So the next slide.
Oh, that looks the same.
It's the same.
Let's carry on. It's such good information. We're putting it twice.
So there's just a visual of what we've just talked about there as well, but that'll be available on the that'll be available. We'll send the slides out. But I think the other things to talk about there are things like the Wise Up workshops and all the other training that we do. So we're training on sleep, training on, there's a plethora of it. So there's sleep, there's how to understand your neurodiverse child, how to look at anxiety in the context of that. So there's a whole long list of workshops that parents can go to, and that we are doing through other projects as well. And I think it's also really important to understand that all of that is available. for families without a diagnosis. So the young person doesn't have to have had an assessment and had an outcome of the assessment for those things to be relevant and available. They might have had an assessment and not had the outcome they want. They can still attend these workshops. They might not have had an assessment. A young person might not want an assessment, or everything is sort of everyone can turn up. It's very inclusive, and we like people turning up to those.
It's the same with the so the ADHD training this year has finished. That's I've been delivering. I delivered 3 times this year through the DP service. It will be continuing next year. I haven't finalised the dates yet or what it will look like, but that offer will be opening up. But I think previously we said that children had to be on the pathway. That shouldn't have to be the case. I'm waiting for confirmation, but I'm pretty sure it will be as long as the young person are in Somerset. So what we're trying to do is all the time think about if we are suspecting that there is additional needs going on that might be neurodivergent, or that just you're seeing something that could be something like ADHD or could be something like autism. It's good to have those conversations and to support parents to kind of think to go to some of these places where they can inform themselves to think about, is this a process which I want to learn more about? It's also not committing them to anything. So if they were to say sign up to this stuff, it's not like we're saying, or it's not a commitment to say this is the path towards diagnosis. It's more of an exploration of, is this something that they feel matches with what they're seeing, and could it be a helpful process for them? So
and I think because of that, the one we do on how to talk to your young person about neurodivergence and neurodiversity is one of the most popular ones, because it helps our families to begin to have those conversations, doesn't it? But some of the other ones are very much support focused. So if you go to one on sleep, you can go to that regardless of what's going on, if sleep is challenging for your young person. And we've had families come to them a couple of times if they want to. Some of them are in person and some are online. There's a question in the chat, Mary, about
I was just looking at that,
training in schools as insets.
I mean, so one of the things that we have been talking about, and whether we could, I think we would struggle to get around to all the schools in insets, but I happily catch up with you, Jo, about what kind of training you were thinking and looking for. And because one of the things we have been thinking about is creating videos, recorded training videos from our team that could be used on things like inset days, keeping them quite short, but sort of short and snappy, and ones that then could be used for families as well. So that is something that we have got as part of our development program for next year.
We have done it before if there's a group of schools, or we've done it like to the Prues before and things like that. So it's easier for us if there's a group of you that can get together, because we don't we have to fit it in as extra stuff, but we're something we'd always look at. So do get in touch with us and we can look at the logistics of it.
Yeah, absolutely.
It might be quite a nice one. I know we don't really do pyramid school as such anymore, but as in terms of, if you think about your feeder schools and things, if you could come together and think about if you want to do something like that, it would be far easier for them to deliver. Okay, post-diagnostic support, Charlotte.
So the next bit, we were just going to talk about the ADHD pathway. So what we wanted to, the question earlier, asking about, so the plan was to link that back, but I know I've sort of mostly answered this question already. But we would need to ratify any private position, any private assessments, but also any right to choose assessments for them to then access the post-diagnostic pathway. What it really clearly says on the private position statement is that if you've chosen to pay for medication, then that medication you'll need to continue to pay for until you have reached the point, and it's actually point number 6. So there's quite a time to go through. So obviously
that's what I was just going to say. Families need to be aware, don't they? They're probably looking at around 12 months of having to pay for private prescriptions if they choose to start medication on the back of a private diagnosis. We can't push those ones through any quicker.
No, absolutely. That's exactly right. So the way the post-diagnostic pathway works is that obviously if they have an assessment with us, we'll go from there, or their assessment is ratified. They would have their assessment feedback and they'd be transferred to the ADHD pathway. They would have their report sent through to them. They would then have a patient-initiated follow-up, which they have to instigate within 3 months of receiving the report. They will then get offered the Understanding ADHD course at some point during the following term. At that point, they would have not at that point. After scaffolding, like we talked about earlier, for roughly 6 months, they would then have an appointment with an NMP. From point 1 to point 5, we, like Charlotte was saying, we're talking around 12 months for all of those things to be able to be in place and to make sure that that's working. They would then, if it's then felt after the holistic review that medication is one of the other scaffolds, having done, so learned all of those other skills and scaffolds, and they feel that so that is the right thing to consider, they will then be offered an appointment with a paediatrician or a psychiatrist, depending on who the most appropriate clinician is for them to see. At that point, there might be 2 outcomes. So it might be that medication is deemed to be safe, appropriate, and the right thing. And not all young people, not all adults, not everyone is clinically safe to be on ADHD medication, on stimulant medication, but also if they are on medication, they will then have 6 monthly reviews, and if they're not on medication at that point, then they will have advice and guidance via the helpline if they need it, the ADHD helpline, so it's a different helpline with our neurodevelopmental nurses, and then they will be offered an appointment if and when it's required for them, rather than on a rolling 6 months.
And before we get the question about that helpline phone number, we can't give it out to you. It is only given to the families when the young person is diagnosed, because it is only for families who have a diagnosis of ADHD. So anything else, ring our normal office number for kind of queries, or the telephone advice line if you want to speak to someone about pre-assessment support. So we're not being difficult there, but we just need to keep that number free for the families where there's a diagnosis of ADHD. I was just going to add, Mary, it's very similar to the assessment thing as well, isn't it? Young people have to want to try medication. So there's lots of considerations. We have some young people who very much want to try it and they get on well with it and it works really well for them. And we have other young people who really don't like how it makes them feel and they don't want to take it on an ongoing basis. And we have a small number of young people who are not suitable to take it, often because of cardiac problems in the family or sudden death in the family. We have to be very, very careful when we're giving stimulant medication. So it's really important that we're all making sure we're not holding medication as some amazing answer and promising that the young person will be going on it and it will make a difference, because there's so many factors to consider before we can use that. And most of our young people don't use medication all the time. They'll use it for short periods of time, often during the school week or during exam periods or things like that. It can be an amazing option, but it's only one of the supports that we offer.
Yeah.
Has anyone got any questions about anything that we've covered there or today?
The only other thing I was going to say about medication is occasionally we are aware there are young people where there are very big risks around their ADHD and there might be co-occurring mental health difficulties as well. And so we do in those situations have an expedition process where we can get young people seen more often if there is a very high risk of impulsivity leading to suicide or things like that. Then we can make a clinical decision to initiate medication more quickly, but those are very rare situations. So do discuss it with us if you're worried that you've got a young person whose impulsivity is leading to substantial risks, but we do have to keep those numbers small. Yes, sadly there is still a supply issue with ADHD meds. It's slightly better than it was, but it changes quite frequently still, so and I think it's also tricky because once everyone's got a bit more stock in, then everyone tries to get a few months supply at home and it all feeds into each other, so we don't really know when that's going to resolve. Yeah.
Anyone got any other questions? Otherwise, we'll close the video for this and then we'll open up to just other questions. Okay.
Doesn't look like it. Brilliant.
Harriet, could you stop the video and I will stop